Thank you. Thanks for this opportunity. As you know, in clinical practice, occlusion of left atrial appendage or the LAA with a thrombus inside is considered contraindicated. But there are rare clinical circumstances, as in the present case, that LAA occlusion is needed despite persistence of thrombus. While doing this, there is obviously a concern for thrombus dislodgement. However, which safety measures are recommended in terms of procedural technique are not fully defined in textbooks, but can be found in a few case reports. Each report describes a different aspect of these measures, and in this case, we combined them in a whole manner, and some measures are actually new in the present case. This is my disclosure. The patient is a 59-year-old man with hypertrophic cardiomyopathy and permanent atrial fibrillation. He had a vitreous hemorrhage in the eye while on treatment with warfarin. The ophthalmologist did not recommend to reinitiate any oral anticoagulant because of high bleeding risk. Thus, he was referred for percutaneous occlusion of LAA, and initially a pre-interventional T and CT scan were performed. However, as you see here, pre-interventional T revealed a mobile and seemingly fresh thrombus in the middle of LAA with a high risk of embolism. So, after extensive discussion with the patient about risk and benefits, we decided to perform percutaneous occlusion of LAA with some modifications from the standard implantation procedure and some added safety measures. These safety measures, which are 7 in numbers, are as follows. Number 1, carotid filters, which were embouched in this case, were placed for each carotid artery to prevent stroke in case of inadvertent dislodgement of thrombus. We recognize it would be better to use a dedicated cerebral protection system like Sentinel, if available, but we do not have. Second, since manipulations to achieve coaxial alignment should have been kept at a minimum, we paid even more attention than usual to achieve puncturing fossa ovalis from the inferior posterior region. Actually, in a usual case, it is true also, but in a usual case, it can be forgivable in a site of, apart from the non-inferior posterior region, but this is not true for this case, which has a thrombus. Here, this is our case. This is the bicabal view showing the exact inferior puncture site, and short axis view showing the exact posterior puncture site. And number 3, the transseptal puncture was facilitated by the stylet of BRK needle, or could be the back end of a coronary wire, to release tension on the catheter, because puncture assembly might possibly jump into LAA like a slingshot when popped across the septum, as shown here from another case. Watch is. This is not, we do not want to happen. This is particularly of importance in case of a thick or floppy septum, a facilitated transseptal puncture. And here, after puncture, you see the transseptal sheath across the septum in fluoro and T. And now, number 4. When it comes to sheath exchange, blind advancement of stiff wire towards the left upper pulmonary vein, and that is LUPV, assuming that LUPV is around here. Where is it? Okay. Around here, in fluoroscopic view may be misleading due to anatomical variations and close relationship between LUPV and LAA. The wire may enter LAA inadvertently. Thus, a pigtail-shaped wire, which is less likely to enter LAA, excuse me, but Thus, a pigtail-shaped wire, which is less likely to enter LAA, was used for sheath exchange in the body of left atrium instead of exchange in the LUPV with a stiff wire. It was the inner wire in our case, but could be a Safari or Confida wire as well. We believe this is safer. And obviously, we did not cannulate LAA with a pigtail catheter or delivery sheath. And now, number 6. We avoided to use contrast injection to delineate LAA anatomy. All measurements were performed by T. Actually, fluoroscopic views can be rotated clockwise in 90 degrees as imaginary, and as seen here, they correspond to the T images of LAA in short and long axis respectively. So in the procedure, we focused on these images, T images. We used amulet device in this case. Amulet has an opening order, as you know. First, when it exits the shots, it first has a ball shape, then triangle and the lobe. It is easy to view the relatively atraumatic ball configuration in T. We can be sure that it locates the most distal part of the assembly. So by visualizing this relatively atraumatic ball configuration in the left atrium by focusing on T images, the delivery sheath can be advanced carefully into the neck of LAA without touching to the thrombus, as seen here. And lastly, number 7. In case of a need for repositioning, the device was recaptured only partially to reveal triangular shape, not the ball shape again, inside the LAA without getting back into the left atrium. By its bigger area than the ball, as depicted here, triangular shape could maintain trapping the thrombus behind it. In this video, you see the stage of recapturing. First, the disc of the device was recaptured, and the triangle, and lastly, the ball. As stated before, we stop recapturing at the triangular stage. Here, here you see the first attempt for deployment. Watch that. We also look for T, of course, but you see that there is an unpleasing appearance. So we partially recaptured it and advanced it a bit further, as seen here. This is the second attempt, and we achieved a correct position and configuration. And finally, after verification of 5 stability signs, the device was successfully deployed without complications, as demonstrated here by fluoro and 3D. This is an NFS view of disc showing the nice sealing of ostium, and this is the surgical view. Conclusions. In case of clinical necessity, percutaneous occlusion of LAA with a thrombus inside may be feasible. And some modifications from the standard implantation procedure are of most importance in terms of efficacy and safety. Thank you.
Great case. Any questions from the audience at all? Did you catch anything in the filters?
Sorry?
Did you catch anything in the filters, the carotid filters?
Was there any thrombus in the filters?
No.
And tell me why.
It was clear.
It was clear. Yeah. And tell me why again you didn't have Sentinel, or you did have Sentinel? Or why did you choose those carotid filters versus a Sentinel device?
We do not have Sentinel.
You do not have Sentinel.
Yeah, in Turkey.
That's okay.
We do not have.
That's okay. And Amulet versus Watchman, was there a reason?
Actually, I have slides for Watchman. I know American operators use Watchman, but this technique, this no-touch technique, is not feasible with Watchman because the delivery sheet has to be advanced into LA until its marker aligns with the ostium. But the newer one, Watchman Flex, has some new features compared to the original one. And regarding this issue, it has a ball shape because it has a closed end, and it can be used also at this purpose. It can be repositioned proximally and distally, and it's appropriate for this purpose.
That's great. Thank you very much.